can see the pylorus not always spastic or narrow. In patient with gastroparesis, like patient with achalasia, we go to examine the duodenum, make sure we don't have any sort of mechanical stricture which cause these symptoms, and we go directly for steps of gastroparesis. Usually, I started from here and try to move towards the pylorus. I start around 4 to 5 centimeters proximal to the pylorus. Here we can see we have like a spastic ring here. We should keep this in mind. So we will start after and we go here. We use here a Fujifilm scope, which is a slim one. It's 9.2 for the outer diameter and working channel 2.8. And we will use first the injection. I usually use a needle, injection needle to do this. We use just saline, methylene blue, and a very low concentration of adrenaline. Our patient must be intubated with general anesthesia, and we use CO2 for the whole procedure. We start to suction to collapse the lumen, and I will start my injection here, needle out. One tip to do, I will ask the anesthesia to give like antispasmodic to decrease this.
Dr. Ahmed, can you please explain the advantages and disadvantages of greater curvature versus lesser curvature?
Actually, this is the standard way, inject. This is the standard way. I know some did from enough. Some did from here, from up down, but this is the way. I don't know special, no strong evidence for benefit of one way technique over the other, according to my knowledge. You have any comment about this, Dr. Ammar?
No, I agree.
You think there is any strong evidence about this?
I'm not aware of any evidence. Often if the sister
The
read through GPOM and they attempted in the greater curvature, then usually we go for the lesser curvature. I don't know what's any comments from the audience or the panel?
Yes, I think some in the state do this. Dr. Mu'min with us, if you have any comment, maybe we know something. I'm not sure if there is strong evidence for benefit of one approach to the other.
No, I agree with you, Dr. Ahmed. It's basically operator preference, and I think it's mainly based on how you're trained on doing them. So there are some places that train on lesser curve, and basically their trainees would always come out doing lesser curve and the opposite. But to my knowledge, there is no data that supports one approach against the other approach. The other question that I wanted to ask you also is the incision. Do you make a longitudinal or a horizontal incision in GPOMs?
Yes, I usually did a longitudinal incision, because usually we use hemoclips to close the incision, so it's more easy to close. So usually I use a longitudinal incision. Here I use hybrid knife, T-type. After we do this incision, again, I have some problem with the relaxation and the motility of the patient, so I ask the anesthesia now to give antispasmodic and to little bit.
So Dr. Ahmed is using the Vario 3.
Actually, I need the isolation is not also good.
Endocut I222, and for the dissection, he will be using precise 4.5.
So now after I did the incision, I should cut the muscularis mucosa, as you can see. I shouldn't be shy to cut this, to be able to go deep. And after this, I continue, before I try to go, I continue to cut here and avoid to cut the muscle in the beginning. And I ask the anesthesia to relax the patient more and to revise the isolation, because it's not so good. And I use the hybrid knife to inject more and try to dissect below the incision before I try to go in. It's very important not to be in hurry. Now I think we can go in, but it will be more easy when we dilate enough. Needle in. Now I think this is enough. I make sure of the direction, and I will try to go in. I use the pump to facilitate this. Now I switch the view. Needle out.
So just
try to go in.
Just for the sake of audience,
you
when you
the
decide,
coagulation didn't
can
cut
you hear
well.
me,
I
Ammar?
need to revise the isolation. Now it's started to work.
Ammar, can you hear me?
It didn't work. Yes,
Ahmed?
yes, Momin.
So just for the sake
Yes,
of
we
the
can hear
audience,
you.
when you decide to do a point for gastroparesis, how do you diagnose gastroparesis? What are the criteria? You say, what do you do first? How to diagnose? And then when you decide that the poem is the last resort?
Usually we use, in our practice in Egypt, we use gastric scintigraphy to diagnose delayed gastric empty for solid and the fluids. And also we depend on symptoms and we see the score of the patient. And then we give her the option, or him, the option for treatment. When actually the etiology is idiopathic, the response is not so good. In our series, it's like not more than 50%. 50%. In post-operative, it's better. So that's how we diagnose. We depend on gastric scintigraphy to diagnose the gastroparesis, to diagnose delayed gastric empty, and we don't have a mechanical cause, so we diagnose gastroparesis. We establish the tunnel, but I still have a problem. I need to change the isolation here. So please have another one. We should add our isolation, our neutral, to a larger muscle. You can see here, when I use coag, it didn't cut well. When I use endocut, it cut very well. Usually this happens when I have a problem with the isolation. You can see we have some vessel here, but it's not large. I think we can just cut.
Dr. Ahmed, can you please comment on the type of the current that you're using? I see that the coag current you're using is working really perfectly.
Yes.
So what kind of current are you using?
Yes, Dr. Ammar,
So we're using Bio 3 from AirB. So the incision using endocut I 222, so effect 2, interval 2, and duration 2. And for the dissection, Ahmed is using precise sect 4.5.
Needle in. I will go out, try to make sure we are in the right direction. This is very important to do. Yes, we are in the right direction, and we still have some time here. So I go back again. And this is my direction. Needle out.
Okay.
And I use again the jet function to inject.
We're going to change the ground.
Yes, please do this. They will change the isolation to have a better isolation. You can see here, we're still going to cut, but it looked like a vessel going from the muscle to up. We will isolate right and the left. We can go. Yeah, let's try the new isolation and see if it will make a difference. You can see now there is a big difference. So it's very important technically to know where is the problem and how to deal with. Now we try to isolate this vessel. After isolation, we judge. What do you think, Dr. Ammar? We can cut with the knife, or we have to switch it to grasper?
I think with the precise sect, you can do proactive coagulation of the vessel, and hopefully you don't need.
Yes, but I will try to switch it to soft coag.
Okay.
So sometimes we use soft coag by the knife to coagulate this vessel. So we'll switch it to soft, and we make some stretch. Yes, 6.5.
So switching to soft coagulation, 6.5 now.
Yes. And we do stretch here to the right, and we do press, then we go again
on the other side
to the left. Now it turned it white. Now I think we can switch back to precise sect and we cut.
So
usually when we familiar with this, yes, we didn't need to exchange an instrument a lot.
Yeah.
So
my question... Most of the time wasting in ESD is when you have a device exchange, and that's why you want to try and avoid bleeding, because that's when you take time to really control the situation with exchanging devices. So nicely done, Ahmed. Thank you.
Yeah. So yes, Dr. Momin was going to say something?
Yes, I was wondering, if this failed, what is your next... You said in your series, the poem here is successful in more than 50%?
Yeah.
Not more than 50%.
So if you fail, what is your next step?
Yes, actually, if G point failed, we send the patient for surgery. Sometimes they do gastrojejunostomy. Some patients, they do like some bypass. That is our practice when the patient still symptomatic, have a high score of gastroparesis, and not responding to G point. Actually, in our experience, all patients who did because of post-operative insult, they respond very well. But the idiopathic, our results not so good. I'm not sure what is your experience. I know you do a lot of cases of GPOM. I don't know what is your experience in these patients with idiopathic gastroparesis.
Anybody from the panel?
So basically, at our institution, we have a
have a vessel
protocol.
here
We
also,
typically
switch back to soft
start
coag.
by hooking them up with a dietitian, so adjust their diet first. We do try medical therapy before we even offer them doing GPOM, and then some centers, very few centers, have the gastric stimulator. I'm not like a big fan. I don't have much experience on that, but that's an option. It's a known option. And then the GPOM is the way to go. If they really don't respond to GPOM, they don't have much options. Surgery is an no, GPOM, no, we don't offer gastrojejunostomy for gastroparesis. Most of them who are really that resistant for treatment, they end up with like a PEG, like a feeding tube or something. But surgery, I think, is kind of like an overkill to offer like a gastrojejunostomy, whether it's surgical or endoscopic. I mean, endoscopic is minimally invasive, but we don't offer it for gastroparesis. I don't know if any of the other members of the panel have comments on what do you offer for those who
so, and
do not
what is your
respond to
experience
GPOM
with
as well?
those idiopathic gastroparesis? Because you know,
So
some
the
reports
other
from
question
France,
for you, actually,
they
Dr.
talk
Momin, is
a
about
very good
double
response for those
myotomy.
patients.
Like,
But,
or like, for example, does that make a difference in response, or just a regular GPOM?
I think there was some promising data on that, but I think it's just like you're adding too much to the technique. And if they're gonna respond to a single myotomy, I think you don't need to do a double myotomy. I don't know if it changes much. I don't know what Dr. Khair thinks about that as well, about the double myotomy. We had some discussion in Texas last week about whether we do double myotomy or not, and is it like a full double myotomy, or you extend your, like you're doing like greater curve and you just extend the myotomy on one side more, or you do double myotomy, which is basically lesser and greater curve. We do only just one single myotomy, and typically if you worked hard to select your patient, that would do the job. I think there is a lot more to come, and there is a lot of unanswered questions when it comes to gastroparesis and the role of GPOM. Again, same thing, whether it's greater curve or lesser curve, is there any advantage to do that as well?
I think now we're approaching to the pylorus. I think so, but I just will go a little bit more and check from outside. But it looks like this is the pylorus. Our patient, we ask our anesthesia to relax the patient more because he started to walk up and he tried to help us. I think
basically we have our motility
this
group.
is
So
the pyloric ring,
we
but
do
we
not
need
see the
to
patient
isolate
until
more.
they already have tried diet, they tried medical therapy, and actually most of our patients already have tried Botox, and then they end up our way. If it's secondary to diabetes, of course they need to adjust everything else. So once they have exhausted all the other options, GPOM is the last option that we offer for them.
ممكن نريح العيانه بتحزق جامد. عايزين تخدير بس
We do, yeah.
نريلاكس العيانه شويه.
That's the beginning of the assessment. So they don't even get metoclopramide unless they already had a gastric emptying study that's positive for gastroparesis. So that's the first step. But even with the gastric emptying study, it basically tells you that this radionucleotide is staying in the stomach, but why? We don't really know, right? And as you see, like you look at the pylorus, it's wide open. We started doing also endoflip across the pylorus, but the results were actually more confusing than helping, because you cannot base it on the same criteria with like a DI of less than 2, like what we do with POEMs. So before we do POEMs, we do endoflip, and that's very objective measure. But we found in gastroparesis, it's not as objective. The pylorus is wide open. You do the G-POEM, and they still respond. And the opposite. It's tight. It becomes wide open after you do it, and they don't respond really much. So for after G-POEMs, we have a good response. I would say in the range of like 75%. We have good response. But I think it depends on the selection of the patient. You also want to exclude like functional patients as well. That's a big key.
So,
hello, Mu'min.
Can
you hear us, Mu'min?
Can you hear us?
I have a question with regard to the clinical response post G-POEM for patients with these conditions. Now, I came across a paper that was discussing that maybe the gastric emptying would improve. However, some symptoms, such as the nausea itself, may not really go away. So what's your comment on that?
So that refers back to the same point, is that even with the gastric emptying, it's still not like that sensitive of a study.
Myotomy to show this. So now this is our tunnel, and we believe this is a pylorus. Nice. Let's show it better. This is a pyloric ring. You can see here. And this is behind is the duodenal mucosa.
Right. So Ahmed, how far do you go beyond the pyloric ring?
Actually, sometimes I didn't go so far behind, but when I started the myotomy, it's very easy to cut all the fibers. You know, so maybe I do some injection and try to isolate here. If it didn't work, I will just go with the myotomy and then progress forward. After the myotomy, sometimes it's more easy to do this. So I will try to.
The ring itself, the pylorus.
A
thick muscle.
Integrate a lot. So we have a problem here because I'm going to inject, but our assistant lets the needle out. So I think we have some injury in the duodenal mucosa. I have to check before I go for the myotomy.
So my question is that when you have pneumoperitoneum, whether you are doing esophageal POEM or you're doing here POEM, and you have pneumoperitoneum, what needle you use? LP needle or lumbar puncture needle, or is that laparoscopic needle you use for sucking the air?
I just use 10 centimeter, 10 millimeter needle to do this.
What, LP needle or what?
What we think. طيب شوفوا يا عمار بس شوف السؤال وجاوب على
Sorry, what was the question again? Can you repeat?
If you can't find the needle, the needle in the peg kit can work very well too. You know, the one that's with the tip, with the sharp tip, that you use to place the pull peg, that one works fine too. Yeah.
Okay.
So most of our cases we are using monopolar electrosurgical unit. What about bipolar, like cryo? So do you think there's a different?
That's another point. So I use the cryo system. So for those who are not familiar with the system,
it should be here.
Yeah. This is a good part to watch.
I will clip after the myotomy. So let's see what happened. Actually, here we have, after we go in, we have a mucosal injury here.
Yeah.
I was going to inject, but maybe that was not clear. So our assistant has the needle out, so we have this mucosal injury. We check the injury is down here.
So we'll do the clipping first or myotomy first now?
So we think now to do clipping first for this, or do myotomy and try to do clipping. You have any recommendation, Dr. Kahala, Dr. Mu'min, Dr. Ahmed, to clip first or do the myotomy first, then clip?
I would typically clip this first, right? Because if you haven't done the myotomy, you can still bail out and do a myotomy on the other side. But once you do the myotomy, you will have a full thickness perf at this area. So I would typically...
So you have to do the myotomy. You have detected the defect at the level of the epithelium. At this stage, you have to do the myotomy. You will be able to close that. It's not going to be an issue.
I believe in this. Yes, I believe if I do the myotomy, it will be more easy to close this.
Yeah, so you do the
maybe
myotomy.
From inside or outside.
You do the myotomy, you achieve your therapeutic purpose. You know where the defect is, you can close it. If at any moment you have a problem closing this, and I don't think you're going to have a problem, to be honest with you, you could do it in retroflexion. You'll have to retroflexion the bulb.
Yes.
That's only if you don't see it. But you don't need to do that here because you can see exactly where it is when you're using an axial vision.
Yes. Yeah. So we will go for the myotomy now, needle out. I start to cut a little bit here, then I may switch it to IT knife, but sometimes I use
that's why in general you have to be extra careful when you're trying or reaching the pyloric ring.
Yes.
So Dr. Ahmed is now cutting through the ring.
Yes, I use a coagulation current, then cutting current. I should be very careful here because I'm close to this mucosal defect. I do injection and I pull back to do. This final part I may use IT knife to cut, needle in. I may use IT knife to cut this part. And again, I will ask our anesthesia to relax the patient a little bit more. IT knife, please.
Yeah, thank you.
Ahmed, if I can add also, I think most of us nowadays don't breach the serosa, so I think you'll be fine.
Yes,
hopefully,
yes.
If you just be careful
try not to do this.
with your myotomy and not do a full thickness, I think you'll be just fine, like Michelle said, with some endoscopic clipping. I think you'll be just fine.
Yes. I totally agree. I didn't try to do extended gastric myotomy just to cut the ring.
Ahmed, can you please comment on why you preferred the IT knife here in that part, so you can explain that to the audience?
Yes, because I wanted to protect the mucosa here. Right. So I wanted to not to leave a remnant of fibers, and in the same time protect the mucosa. So I use a knife which can't conduct current to the tip. As you can see, it's only cut down, so we can cut the whole fibers. Now I think we take the whole fibers, maybe little bit is left.
So just to explain to the audience what Dr. Ahmed is using right now, it's a needle that has that white tip, which is ceramic, that acts like an insulator, so it doesn't conduct the current, protecting the mucosa on the other side of the needle.
Needle in. Yeah. You can see here the pyloric ring is to the right and to the left. Yes. All this is ring here, right and left, and I think we're done. Maybe I cut a little bit more here, needle out. Okay. Now I will try to do like a double myotomy here, aiming to improve the outcome.
So it's like they clipped the mucosal injury from the inside. We can't hear you, Dr. Ahmed, and the rest of the team, but we can see the mucosal injury being closed from the tunnel itself.
Yes, we close from inside.
You can hear now?
You can hear us?
Yes, we can hear you.
So we close from inside. We complete the double myotomy here, and we close from inside. And from outside, usually it looks like this. You can see here was the defect.
V-shape.
This one,
6 o'clock.
Yes, 6 o'clock. Here was the defect, and we have some experience to close from inside. It's more precise, and we are more comfortable because here we are afraid sometimes when we close here, we cut more mucosa. And actually, we publish this technique in endoscopy, and now we try to close our incision here. Okay.
So Ahmed, I know you're a big fan of closure from the inside, and you published on that, which is very interesting. and the closure you did here looks really perfect. But do you have any long-term concerns about that